Imagine this, you're exhausted, dragging yourself through the day, struggling to focus, maybe snapping at people you love. You go to your doctor hoping for answers. They suspect sleep apnea, and before long, you're sent for a sleep study. You're wired up, monitored overnight, and the results come back. You stop breathing 12 times per hour. It sounds alarming. You're told this number, your apnea-hypopnea index, or AHI, means you have a condition that puts you at risk of heart problems, cognitive decline, and chronic fatigue. You're prescribed a CPAP machine, a device designed to keep your airway open while you sleep. The logic seems airtight. Fewer apneas means better sleep and better health. But here's the problem. For many people, this story doesn't end the way doctors expect. The numbers improve, the graphs look perfect, but the patient doesn't feel any better. Some feel worse. And yet, the medical system congratulates itself because one number, AHI, went down. This is the CPAP paradox. So to really understand the paradox here, we need to look at the underlying assumption. The idea is that apnea events cause poor sleep, and that poor sleep leads to daytime symptoms like fatigue, cognitive decline, and even cardiovascular risk. That's what folks call the linear model. The reasoning goes, if you fix the apneas, then everything else is supposed to get better. But what if that's not the whole story? Now, when we actually test this causal link in some pretty large studies, the results turn out to be, well, mixed. CPAP almost always lowers AHI, which means the number of breathing interruptions per hour. But that doesn't always translate into better sleep, better focus, or better health. For example, the SAVE trial, which followed more than 2,700 patients, found that CPAP did almost nothing to reduce cardiovascular events, even in people with severe apnea. Other studies show something similar. The machine can fix the number, but not necessarily the outcome. This raises a question we should have been asking all along. Are apneas the disease, or just one symptom of a larger problem? Here's an alternative way to look at it. What if apnea, poor sleep, and daytime impairment are not cause and effect at all, but co-effects of some deeper shared driver? Think about what we know about physiology. There are, many underlying factors that can disturb sleep and breathing simultaneously. Chronic inflammation, metabolic dysfunction, autonomic nervous system imbalance, ventilatory instability, even psychological stress. For some people, the airway collapsing is the main problem, and CPAP works beautifully. But for others, the airway collapse is just one symptom of a system already under strain. In those cases, forcing the airway open with a machine may improve the numbers without touching the root cause. And when the deeper driver, let's say chronic sympathetic activation or poor arousal regulation, isn't addressed, patients can wake up feeling suffocated, anxious, and unrested, exactly as many do. If this were just about biology, we might already be doing better. But this is also about incentives. In today's clinical model, the single number, AHI, dominates everything. Sleep studies are designed to measure it. Insurance companies reimburse based on it. Doctors are trained to see it as the deciding factor. Here's how it plays out. You walk in with vague symptoms like fatigue or brain fog, and if your doctor suspects apnea, you're sent for a sleep study. But there's no standardized testing of daytime functioning, no baseline assessment of cognitive performance, mood, or cardiovascular markers. The assumption is, we'll measure AHI, and if we fix AHI, we've fixed you. That's how we end up with borderline cases, folks with mild apnea scores, being prescribed CPAP. Even though, honestly, the likelihood of meaningful benefit is low and the risks of harm are real. If you comply and feel better, the system declares victory even if the improvement came from something totally unrelated, like the placebo effect, reduced anxiety, or just believing you're doing something about the problem. But if you comply and feel worse, well, it's written off as an adjustment period, not a therapy mismatch. This is not patient-centered medicine, it's metric-centered medicine. We don't need to throw CPAP away. For some people, it's life-saving. But we really need to stop treating AHI as if it's the only indicator of who should get it and who will benefit. The better model starts with broadening what we measure. Before prescribing CPAP, we really should be testing daytime sleepiness using standardized scales, measuring functional cognitive performance, assessing sleep architecture, and where it makes sense, capturing autonomic and metabolic markers that actually predict harm. And crucially, we need to define what success looks like before therapy even begins. If the goal is better alertness, well, let's measure that. If the goal is cardiovascular protection, let's test markers like blood pressure variability or nighttime oxygen stability. Then we can track whether CPAP is truly helping or whether we need to look a bit deeper. This approach really opens the door to personalization. For the person whose apnea is positional, maybe therapy is as simple as retraining sleep posture. And for someone whose breathing instability is driven by anxiety or high loop gain, perhaps relaxation-based therapies or low-dose medications are more effective than positive airway pressure. And for many, optimizing nasal breathing, jaw positioning, or strengthening airway muscles may be the first step, not the last resort. The promise of sleep medicine was better rest, better health, and better lives. But, oh boy, we've gotten lost chasing a single metric at the expense of the whole patient. We need a broader, more integrated approach, one that measures the outcomes we actually care about and matches therapies to individual mechanisms, rather than forcing everyone through the same pipeline. If we can expand testing, shift our focus from fixing numbers to improving lives, and respect the complexity of sleep physiology, we can transform treatment from a one-size-fits-all device dependency into truly personalized medicine. Because in the end, what matters is not how many apneas a machine says you had. What matters is how you feel when you wake up, how clearly you think during the day, and whether your body and brain are actually healing while you sleep.